It's thrilling to be here with you all today for the 5th conference. This has been incredible. I've been a Good Samaritan for 5 years, and the program's been in place for 6 years. And the incredible growth in the service to the community that's happened as a result of this is unbelievable. And it's because of the dedicated team of many of you that work day in and day out to make sure that we take care of these patients and that we have excellent quality for what goes on. So that's wonderful. I'd like to thank you all for coming. I hope you find this meaningful from an education point of view, and thank you.
I want to invite our Chief Quality Officer, Dr. Kadial, to give a greeting to the conference. Thank you.
Thank you all for inviting me. This is so impressive. I'm impressed by the amount of work you do, your team does, Kimon. I'm impressed by the outcomes you guys have, and I'm impressed that in 5 years you've come so far. And I hope in another, I would say 2, it would be all over Long Island, right? That's what we want our program to be. So you guys have an amazing program. It's a full court press, right? So taking care of patients from the ED, in-house. Let's not forget the live OR case, which will be so exciting. And then taking care of them in rehab, right? I'm really happy to see that we are taking care of patients, not just initially stabilizing them, but really taking them as they go back into their world, where we got them from, right? That's the job, not just to save them, bring them back to stability, but also bring them back to how they started and really get them functional. And I'm really happy that you guys have this amazing program to get our patients there. Thank you.
All right. Dr. Donnarumma is our Chief of Neurology and Chief of Stroke for Good Samaritan University Hospital. And she's going to talk to us about advances in the medical management of acute ischemic stroke.
Welcome. So we're going to talk a little bit today about advances in medical management of acute ischemic stroke.
The most important thing from that point is history and imaging. The last one just says, don't ever use heparin to treat acute stroke. It's even worse than everything that causes people to bleed. Thank you.
So speaking about mechanical thrombectomy for stroke, again, how long do we have to intervene? So a lot of these studies, we talk about TPA in the past and how we only had 0 to 3 hours to intervene. And then we were able to extend that time for certain individuals to 4.5 hours. And now we're talking about intervening for stroke all the way up to 24 hours out from symptom onset. Patients also were having lower MRS on discharge and at 90 days out, which is, again, the goal. So finally, we'll talk about RAPID. I've mentioned it a few times. It's really an artificial intelligence software that we have integrated into our everyday practice at this point. We've been utilizing it for a few years now, and it's become part of our everyday practice. Our entire team now can read perfusion studies within 5 minutes from home. And we basically, we might have a team here ready to do a stroke before we actually get the call from the hospital these days. That's how much time that we've been saving with this process.
I wanted to add one more thing you said about effectiveness of mechanical thrombectomy. The comparison is pretty much to the antibiotic use. It's so effective and it's so strong that it's very much comparable to the time in the 1950s when actually the antibiotics were introduced. So it's such a big thing. So before we get into a case, actually we have to consider very quickly, we are talking about seconds, and I'm not kidding, to go through all these things, because some are our experience we're building over years and years. And then when we see a case, we really want to get as fast as we can on the angio table if it's a good candidate for thrombectomy. So what's the goal, I believe, and there are more and more data supporting that when you do sub-maximal angioplasty, so you intentionally don't want to have a good result because you are pushing the plaque in the perforators. So you do an angioplasty, you wait like 10 minutes, you see where the things goes. If the artery goes down, then you have to put a stent. There is no way. I usually try not to, but if there is no other way, then yes, that's the solution. And then you start with antiplatelet medication and so on. So the risk is higher for bleeding, of course.
Thank you very much.
Again, we've all heard about how significant the morbidity and mortality of stroke is. It's the second most common cause of death globally, and the most common cause of acquired disability in adults. It's all based on the principle that the skull is a fixed volume, and the volume of the bone and the cranial cavity doesn't change in adults. So what's in it? If you break it down in very, very, very simple terms, you have the brain, you have blood, and you have spinal fluid. And this is one of the first things we learn in neurosurgical residency, and it has a name. It's called the Monroe-Kelly doctrine. But essentially it says that if you introduce something else in this cranial cavity, the volume again will not change, so something has to give. So if you introduce a brain tumor or a bleed or swelling, edema from a stroke, then what's going to happen is initially the brain will try to compensate itself by pushing spinal fluid out of the way and sometimes pushing blood out of the cranial cavity, which is bad because it will cause more ischemia. But at some point, all these compensatory mechanisms will fail, and that's when the pressure will start increasing. And once the pressure starts increasing inside the cranial cavity, it's going to start causing more damage because you already have the damage from the ischemic insult, from the completed stroke, but now you introduce added injury, mechanical injury from the increased intracranial pressure. And if it's a large territory we're talking about, and if it continues unchecked, that can be fatal. So in these cases, if we see a large infarct and we see progressive edema and we're starting to see this mechanical injury and we see this on the CAT scan as shifting in the brain, so essentially the swollen side is starting to push on the normal side of the brain, this is a procedure that patients are candidate for. So what's involved with a decompressive craniectomy? It may sound very strange, but again, it's a way for giving the brain more room to expand and swell. And the swelling doesn't last forever. Just like the way I explain it to patients is just like you hit your arm, you get a bruise. It hurts, it swells, it changes colors, and then the swelling goes down. It takes about a week, sometimes 10 days to do so. Something very similar, again in very basic terms, happens to the brain. It swells, but eventually the swelling goes down. But during that time, if there is not enough room and the pressure goes up, more injury can happen. So it involves making a large incision on the patient's on the side of the head, whether it's the left or the right. Typically the incision looks like a question mark, and then removing a large area of the skull. And then we close the skin. Again, it sounds very strange how someone can walk out, can be functioning or alive without part of their skull. But again, it works very, very well in most cases at giving the brain enough room to expand and controlling the intracranial pressure and avoid the further mechanical injury. This is a CAT scan of, on average, what it looks like. Again, you can see the stroke as the dark area. That's the progressive ischemia. You can see the ventricles in the middle, and you can see how the CSF is getting pushed over. The ventricles are getting smaller, and then slides 3 and 4 are after the craniectomy. So in closing, this is a life-saving procedure. There's no doubt about that. Every study has confirmed that. What we know is that 43 of patients with modified ranking scale 0 to 3 in the European trials. When you looked at patients over 60, only 7% had a modified ranking score of 0 to 3. So we can help, we can achieve survival, but there is still the cost of disability. So an honest discussion needs to take place with the family, and they need to know that when they sign up for this procedure that their relative will continue to have some disability. They may still need a feeding tube and chronic care afterwards. Thank you.
We're gonna shift gears here now a little bit, but basically we're talking about the secondary prevention of ischemic stroke, and by secondary we mean that the patient has already had a stroke or a TIA, and it is our job now to make sure they don't have another one. In general terms, preventative strategies, which we'll speak about a little bit, include antiplatelet drugs, but just as important, if not more important, is management of risk factors. Most significantly, hypertension, but hyperlipidemia, blood sugar, atrial fibrillation, these are all very important. You can see the CAT scan in this person was normal, so this is somebody who's had an acute ischemic stroke, negative head CT at presentation, very common. And this is what you might see. A patient like this might present with acute language deficits, expressive in particular, Broca's type aphasia. They may have right-sided weakness. And these are large vessel strokes. They're cortical. They're most commonly due to emboli from somewhere else. They're most commonly due to a clot traveling from one spot to another, most commonly the heart. If a patient fails maximal medical therapy, then we do call the interventionalist and ask them to intervene. Thank you.
What's happening behind me, behind this glass, is a whole team of people who I'm going to introduce you to in a little bit. And they're getting, what's going on is that they're getting access to the carotid artery. They've already gotten access to the femoral vein. And pretty soon I'll be in the room and I'll take you through how we fix this problem. What we're doing, carotid disease is significant because of the risk to cause a stroke, right? So when you build up plaque in the carotid artery, parts of the plaque can break off, they can travel inside the brain, and when they do that, they can cause a blockage and a stroke. The way to prevent that from happening, if you know that you have carotid disease, obviously, is to remove or eliminate the plaque and that potential. There are guidelines that we follow, so if carotid is blocked over 70%, then that's an indication for us to treat 70 to 80% if the carotid plaque hasn't caused symptoms. If the carotid plaque has caused a stroke, then we can go down to 50% as a cutoff for intervention. So the way we treat carotid disease traditionally is with what we call a carotid endarterectomy, where we make a relatively large skin incision in the patient's neck, and we scoop the plaque out. We remove the plaque out mechanically. All right, so can you guys see the carotid artery now? All right, so this is the carotid artery.
I'm talking about this year about posterior circulation strokes. As many as 165,000 strokes a year may be misdiagnosed in U.S. emergency departments. And presenting signs and symptoms are often nonspecific and fluctuating for posterior circulating strokes. Posterior strokes are 3 times more likely to be misdiagnosed. Hence the reason we have that B and E attached to the B fast. The B is for balance, and E is for eyes and vision. That's focusing on the posterior circulation strokes. Often very hard for the emergency room physician and staff to discern what exactly is the cause of the vertigo. So for posterior circulation strokes, you have to ask some probing questions with the patient's symptoms, all right? They call it the 5 Ds of posterior stroke. Patients presenting with dizziness, all right? Is it a sudden onset? How long has the dizziness been going on? Does the dizziness resolve when you're laying down? Does it get worse when you're sitting up? Does it get worse when you're standing? Is it continuous? Okay. Diplopia, is there any vision problems associated with your feelings of vertigo? Dysarthria, is the patient having any difficulty speaking associated with the dizziness? Dysphagia, this is, all our patients get that swallow test. Certainly when someone comes in with dizziness, this is something you want to be mindful of. Patients with posterior circulation strokes can certainly have difficulty swallowing. and dystaxia, something that a lot of times gets overlooked. The patient is so dizzy, they're laying in bed and they're dizzy, and if you don't get that patient up and stand them, try and stand them, or try and walk them, you might miss the fact that they have an ataxic gait, which is a clue that this could definitely be a posterior circulation stroke. All right. So areas of the brain affected by occlusion in the vertebrobasilar artery system, they divvy it up. You can have in the medial, temporal, and parietal lobes. These patients that come in, they complain of dizziness, nausea, vomiting. If they end up having a stroke in the parietal lobe, they can have end up with memory deficits, alexia. They could have difficulty reading. They could end up having difficulty with small math calculations. Agraphia, they can end up having difficulty with writing. Okay, and there's prospasmognosia. That's a very strange term. That's inability to recognize face recognition. We did have a patient who had a parietal stroke, and thankfully his symptoms did improve, but initially, after his stroke, he was, back when we gave TPA, we did give that individual TPA, but he was having problems with facial recognition. He wasn't recognizing his family members. And he would say, I don't recognize their faces. It was so bizarre. But those symptoms thankfully resolved, but he did have a parietal stroke, so that was very interesting.
I'm going to talk a little bit about some minimally invasive treatment for spontaneous hemorrhage in the brain. I'm going to be talking more about that red zone in there, which basically occupies about 10% of strokes. This is when you have spontaneous hemorrhage associated with the stroke. So we deal with a little bit different type of injury when there's a hemorrhage. There is an initial hemorrhage, which is the primary lesion when the blood dissects through the brain and damages the cells, and then there is potentially a secondary injury from what is believed to be a cytotoxic effect of the blood on the surrounding cells that have not yet been damaged. This is where the theory of getting in there and removing blood was born once some in vitro studies demonstrated that decaying or dissolving blood may be somewhat detrimental to healthy brain tissue during a primary intracranial hemorrhage. But this is a picture of a classic spontaneous intracerebral hemorrhage. It's in or around the basal ganglia. Could be hypertensive, it could be amyloid, it could be a lot of different things. But this is a large portion of what we see. Certainly the hemorrhage can be lobar, meaning contained more peripherally in the frontal, parietal, or even occipital lobes, period. The standard training, historically, when you go through neurosurgical training, you're taught to be somewhat conservative with these. We generally don't try to open the skull and remove blood unless it's absolutely necessary. It's like a bruise in your body. Your body is going to absorb the blood by itself, so there's really very few implications. Well, at the time, there was very few indications to open the brain just to remove blood that was going to be absorbed anyway. This is an example of what's not clinical equipoise. This is obviously, there's massive hemorrhages here with significant mass effect and midline shift. 100 doctors in a room, 100 of them would say this needs surgery for decompression. What have we found out about doing surgery for spontaneous intracranial hemorrhage? Well, the jury is still out. We know that craniotomy doesn't help. It has not changed much as far as outcome, survival, and mortality. But when doing it minimally invasively, there are studies that show a trending improvement in their function and a little bit improvement in long-term mortality. But we cannot yet make a level 1 statement or even a level 2 statement saying that minimally invasive surgery for evacuation of these hematomas is indicated. Again, it's case-by-case basis, user preference, and again, it's family preference as well. Questions?
My name's Ruben. I'm one of the neurologists at Good Samaritan Hospital, and we're going to be talking about cerebral venous sinus thrombosis. Not going to get into too much detail on this slide, but what I'd like for you to get out of this is these are the major venous structures in the brain. You have things like the superior sagittal sinus, transverse sinus. These are some of the structures that we're going to be talking about on rounds where the most common venous occlusions are going to be identified. Epidemiology, thankfully this is an uncommon disease, about 2 in 100,000, and as if women don't have enough to deal with it, 3 to 1, right? But there is a good explanation to that, which we'll get into later. It is a disease of the young, which is a little different than some of the other vascular problems we see. Mean age is about 37, and thankfully low recurrence risk, which is different than the arterial problems that we have. People have arterial strokes, I wouldn't say high risk, but certainly much higher than venous. A lot of words on this slide, but the pathogenesis comes down to really one word. It's pressure, right? You block a vein, you narrow a vein, and the veins pretty much everywhere, but definitely it's 100% in the head. They're draining via gravity, right? If you have any abnormality in those veins, that's going to cause pressure to build up. You're going to have increased venous pressure, capillary pressure. That's going to lead to breakdown of the blood-brain barrier, edema, and that leads to the strokes and the hemorrhages that we see. True or false? Women are more likely to suffer from CVST. True, yeah. CVST is more predominant in older patients. False, right? It's younger. And there's a high recurrence rate in CVT. False, that's right. Thank God. Find the risk factor, right? That's right, pregnancy, yeah, and oral contraceptives, that's right. And meningiomas, right? They're benign finding in the brain. Most sensitive diagnostic test, MRI. MRI may not necessarily be the first test, but certainly the most sensitive. Who warrants a hypercoagulable evaluation? That's right. Patient with a history of transient prothrombotic event or state? No. No, that's someone who you'd say not to do it, right? Because we found the reason why, and it's something that's going to go away. Patient with a family history. A lot of the prothrombotic conditions are genetic. Medical therapy? Correct. And the reason why I wrote anticoagulation is you have options. All of them are essentially equal. Okay, true or false? Intracerebral hemorrhage is a contraindication for starting anticoagulation. False, exactly, exactly. And this piece of information, if you remember one thing, right, this is something that, if you remember, every single, whether you're a nurse, a therapist, a doctor, a neurosurgeon, right, you're going to come to this patient, you might have some very valid questions about what on God's green earth is this doctor doing? The chart is riddled with notes saying there's blood in the brain and they're pumping him with heparin, right? So now you know, makes sense, right? True or false? Endovascular therapy is reserved for patients who continue to deteriorate despite best medical therapy. Yes, yes, exactly. Again, these people are young for the most part. We want to give them the best chance of survival. Start antiepileptics on all patients with CVST? False, right? People who come with seizures or people who have lesions in areas that are epileptogenic. Cortical, mostly cortical findings. Oral anticoagulant, false, exactly. Yes, yes, much less controversy than there was even 5 years ago in regards to this question. Okay, true or false? Duration of treatment is dependent upon presence of thrombophilia, risk factors, and precipitating circumstances. Yes, that's correct, right? If you got a transient risk factor, 3 to 6 months. If we have no idea why you had it, and you went, it's a one-time occurrence, and we did the whole gamut of workup, 6 to 12. If you got a long-term issue that we've identified, lifelong ACE. Okay, and which is not a predictor of mortality? Hyperlipidemia, right? All the others would. And that's it. Thank you so much. Look forward to seeing you in the hospital.
So I'm going to talk to you today about intrasaccular devices. These are devices that are a way to treat aneurysms, and you'll see how they're similar to coils, but vary a little bit in how they're deployed and how they're used and how we think about them. So Kimon talked a little bit about flow diversion. And that's one of the most common ways we treat aneurysms now. That's in the upper left. And that, like Kimon said, is a fine meshwork that basically redirects blood flow away from the aneurysm. The second picture is a coil. The third is an assistive means to keep a coil in place. So that question about whether or not a coil could fall out, this is, in fact, the next three are ways that we keep that coil in place within an aneurysm that's got a wide neck. And the neck of the aneurysm is basically where it comes down and meets the vessel. And you can imagine that if that is wide, it can then fall out. If it's narrow, once the coil takes its shape, it's very hard for it to fall back out. And in recent years, they've developed some new devices. In the bottom left, that's a Comaneci device. It's basically a stent that's on a stick and allows you to place the coils, and then take it down and remove it. And similarly, a balloon can also be used to keep that coil in place. Now, intrasaccular devices are a little bit different. In my mind, I kind of divide them into two general categories. The first type is an intrasaccular flow diverter. So these are big devices that basically fill up most of the aneurysm. And the point of them is that on the lower aspect of it, it diverts flow away from the aneurysm, much like that flow diverter that Kimon showed with a stent that's actually in the vessel. And then the other types that they're developing and calling intrasaccular devices are these neck bridging intrasaccular devices, which is basically a stent that sits inside the aneurysm. And it works as a stent, but again, it doesn't pop out and sit in the vessel, which is really important for things like anticoagulation and in the setting of rupture where you don't want to give a bunch of antiplatelet medications. So when Kimon first asked me to give this talk, I was running through my mind, there's only one intrasaccular device that's really approved for use in the United States, and it's Webb. This is the first device that was approved, and it's gone through a couple iterations, but this is what it looks like. I guess you can kind of picture it as sort of the shape that the coils altogether would take, but the center of it is hollow. So it's just a meshwork, and as it comes out into the aneurysm and expands, it kind of holds itself in place with radial force pushing out. And the bottom of it is about 60%. As Kimon said, some of the flow diverters are like 20 to 30%. The bottom meshwork is almost 60%, so that helps to redirect flow away from the center of the aneurysm. The mechanism of action, as I mentioned, looking at the part that's in the middle, you're looking at it straight on as if you were in the vessel, and you can see how tightly the mesh is sitting there. And the lower left is actually an explant from a dog model where they looked at what happens after months. And this is what happens with flow diverting stents as well. Basically, cells grow into that meshwork and completely exclude the aneurysm from the circulation. So in a way, that's honestly one of the best cures that we've ever come up with for aneurysms, because there's no way for it to get into the aneurysm. The vessel wall has essentially healed itself. Pretty much it for what's available in the US. Luckily enough, I've had some experience to be able to use some devices that aren't available in the US quite yet, but there's trials going on to make them available, so they're available in Europe. One of the devices is this contour device, which as you look at it, you can see it sort of looks like half a web. It's just the lower basket part. Contour devices, not just for wide neck aneurysms, but also for narrow necked aneurysms, and that would be something that we would normally use coils for. This is another device that I thought was really cool. It had been basically put on the back burner for a while, but I'm hearing some resurgence of it. It's essentially a coil that's got flow diverting leaflets on it. And It's an interesting one that will sort of, you see how it takes shape as in the bottom right where it says B. That's how it comes out and takes shape as sort of a circle. This is another one that came out a while ago. Very similar to Webb in its shape. It has the same kind of idea. All those that I presented are those standard devices that fill the aneurysm sac and provide flow diversion, or in the case of Contour, the main thing that it does is block the neck and provide a way for blood to bypass the aneurysm. Nautilus is this neck bridging type of intrasaccular aneurysm device. If you look here, they're going to deploy the Nautilus, and that's sort of this, it almost looks like a coil coming out, but it's very flat, so it doesn't have three-dimensional shape. They pull it down, and right now it's blocking the neck of the aneurysm. This is a catheter going through the center of it, and that's deploying a coil within the aneurysm. And then they detach both. I think the flow diverting type really holds promise for being this single device durable treatment. So instead of putting out the 48 coils, you put out one Webb, you put out one Contour device. It could really simplify treatment and save us on fluoro time and anesthesia time. We need to see the long-term data before we can really pass judgment on that. And with that, thank you very much. Happy to take any questions.
2019 sort of started this debate, and I know my counterparts will be talking a little bit more. And one of the things, obviously, and we've gone through statistics here, but really why this is still a hot topic is, and I think the biggest topic is the fact that this is still the most morbid disease that we have. When we talk about disability and the care that happens after a stroke, it's still #1 in the world. And one of the controversial topics I'll just briefly touch on that they'll expand on is, do we divert from primary stroke centers and go directly to a comprehensive stroke center with patients that may have a large vessel occlusion or a significant stroke? And I'll go into detail there. That was one of the controversies that came in 2019, first based on a Denmark study in 2016. And then stroke systems. We had to get better. We had to get better at primary stroke centers to get these patients treated and then out if they required treatment. So what are some things that have happened in 2023? I remember we sat here and talked in 2022. What have we done at Catholic Health? We've gone live with TN-Case, and I think most of the hospitals in Long Island have replaced TPA with TN-Case. Now, why? How does this help us? There's still some data that we're looking at, and I'll talk a little bit about that data, but listen, there's no, and Jim, you're gonna have to change your topic from drip and ship to bolus and ship, right? But the fact is we had delays just based on getting that drip, getting them, and if any of my ED nurses are here, you know, you're waiting for that ambulance crew to get that patient ready, and I know Kimon is calling me, John, where's my patient? You know, sometimes that transfer took time just getting those patients on. So now it's a bolus. Now we've gone, and I'll look at some of the data here, but we're even treating patients with IVT in case right on the CAT scan table. This study in 2018 showed that they really could not identify, really, is this a large vessel occlusion or is this a stroke mimicker? There's not one scale that does the work very well. In 2019, actually, Dr. Bekelis and Dr. Misios had published a study looking at all the data in New York State, and really it showed that whether you're a hub and spoke versus a primary comprehensive stroke center, the care for that patient and the overall outcomes were no different. The other things that did come out of the International Symposium that they talked about here, one of them was the fact cryptogenic stroke is seen very commonly. I think it's about 40% of strokes where we don't know what the actual findings are. What they found is if you're actually monitoring that patient more than 30 days, more than 60, they monitored these patients over a year, they did find AFib in a lot of those patients. Now, it's not identified as, is this the actual cause, but there's going to be a lot of research into finding out, hey, is this the cause of those cryptogenic strokes in those patients? The other thing we talked about a little bit also in a couple of lectures was the treatment of hypertension, specifically in patients with acute stroke. And more we're seeing that you don't get crazy with treatment of that blood pressure acutely in those stroke patients. There are worse outcomes. So more to be seen. I think February is the International Symposium, and we'll hear more, but I'm going to give it to one of these guys to continue on the talk. Okay? Thank you.
So thank you for having us today. So again, as Dr. Matthew was discussing, really the big thing is getting these patients to where they need to go. If they don't have an LVO, or if they're having stroke symptoms, get them treatment as early as possible. If you find they do have an LVO, then get them to where they need to be. And really, that's those old commercials. That's logistics. And a lot of work has to go on the back end for each of those patients to have a good outcome. So a comprehensive stroke center isn't useful for your primary stroke centers or your patients if the patients can't get there and be in the right place at the right time. So we started this discussion about bypassing primary stroke centers for comprehensive or thrombectomy capable centers. Dr. Ryan will give a little more in terms of statistics on that. We know there's mobile stroke units in existence already. What happened in New York City with the SLAMS model and bypassing, transporting to the closest stroke center versus that bypass and what the outcomes are. We know, at least on Long Island, that we see shorter times if you go to a primary stroke center in terms of getting connect to place. Obviously, LVOs are a small percentage of all CVAs, so are we then bogging up our comprehensive centers? Having worked at a comprehensive center, I know they're generally fairly busy because comprehensive stroke centers also have a lot of other resources there, so their ERs are packed. And then in terms of even having an LVO, the ones that are intervenable, we're talking about perfusion studies, it's an even smaller number of all of them. So then we'll be bringing all these patients that may not need those services and transporting them further from their families. This is the SLAMs we talked about upstairs earlier, how, again, very sensitive for LVO. However, when you have a tool that's very sensitive, oftentimes it's not specific. So this doesn't account for chronic symptoms. This doesn't account for prior strokes that the patient had. This doesn't account for their encephalopathy from sepsis, uremia, take your pick. So these are all patients that would then end up in a comprehensive stroke center bypassing closer hospital. So primary centers, what do we know? The care is similar both in comprehensive and primary centers in the initial workup. At your evaluation, finger stick, CTs, imaging, pretty much all primary stroke centers at this point, I think, have CT angio 24/7, and that's really what you need. You need to then diagnose that LVO if those symptoms are present. So when to perform a CTA, when to perform CT perfusion, I think we're going to see more and more push to performing CT angios early on, even in very mild strokes. There's been some very surprising LVOs that I've personally found. I think Kimon can talk about some of them that we've sent to him and to St. Francis. But I think there'll be more and more push for earlier CT angio in all stroke patients. And then CT perfusion, is it available? So we know it's been fairly limited, but we're happy to be adding it to programs across the system. So we know the old goals for getting patients out. We want to get these patients to the definitive treatment as quickly as possible. So old goal was 120 minutes. I think people did fairly well with that, so they dropped it to 60. Now it's a challenge. So how do we get closer to that metric or meet that metric? So coordinated communication. A transfer center was absolutely crucial to this process. So the development of the Catholic Health Transfer Center and continually improving processes there. Having those on-call lists updated, readily available for everyone in the system to see, not just for the hospital, not just for the transfer center. Having ambulances available. I know at St. Joe's they have one essentially outside. Our process for LVO is a little bit different. We actually call the transfer center and put an ambulance en route to ourselves for potential transfer as the patient is going for their initial CT and activating the neurointerventionalist. So if that patient does have an LVO, that ambulance has 10, 15 minutes to get there while the patient's still on the table. So one of the new things coming to our facilities, hopefully in the next couple of months. So this actually originated from air medicine and trauma centers in rural areas. A button placed in the ED. It could be worn around the doctor's neck. I don't think we're going to be doing that. We'll probably have a location. But essentially, you push the button, you say whatever what's in the glossary. So stroke, LVO. You get to define the glossary. That alerts an ambulance, sends it out for dispatch, notifies the transfer center dispatcher what it is. That dispatcher can then get in touch with the neurointerventionalist, be like, this hospital has this case, three-way that phone call, and it saves that time waiting on the phone, making the phone call, looking for the number, whatever the case may be. So transport staging. So for us, like I mentioned, EMS is off-site. That's the case at probably most hospitals where they have to get an ambulance on-site to do a transfer. So it really requires that coordination, that three-way, if not four-way or more call in terms of coordinating with the neurointerventionalist, with the nursing supervisor at the receiving hospital. When I started, it was TPA in 3 hours, and that was it. As we know, we have a whole world of change in stroke in the past 10, 15 years. So we all look forward to these other options, and we look forward to the changes coming and improving stroke care for our patients. Thank you for having us. And then we're going to bring Jim Ryan up.
All right, good afternoon, everybody. Actually, I have the official title of my presentation here, Transport Decisions in Acute Stroke. So I did change it a couple years ago. But I'm going to chat a little bit today about some of the information we have that's recent. In my other role, I chaired a protocol committee for Nassau County REMAC. We review this data regularly to determine where our ambulances go. and we made a decision not to implement a bypass or diversion protocol for stroke patients in the county based on some of this data. LVOs are only 10 to 15% of strokes, so the minority of strokes. The second part, which we all know, and we've seen a great work that our interventional team does, is that they do a great job at opening them. So we really want to get these patients to the correct spot, but we don't want to get the patients who don't need to go there and delay other treatments they might need. So this is kind of the model. The two models, the options that are in effect right now. The one on your right is try to determine which patients are LVO patients and get them to the comprehensive center, and get the non-LVO patients to the primary stroke center. What happens with that? Well, it might delay TPA if you send the wrong patients to the comprehensive stroke center and it's further away. On the left, the model which we're using in Nassau County is a drip and ship model, where everybody goes to the nearest stroke center. Obviously, it might happen to be a comprehensive center, but if it's not, they go to the primary center. And this has the potential disadvantage of delaying a thrombectomy. Can we identify LVO patients? And two former speakers touched on that a little bit. That's very difficult to do. The next question, which is even more important, is can we identify stroke patients? One of the problems with a lot of the stroke research projects that have been out there is they look backwards. In other words, you take a neurointerventionalist or a neurologist, and they look at their patients and look back and say, oh, did we identify them? When you're an EMS provider, you go into the house of somebody who's unresponsive and say, is this a stroke? Could be toxicological, could be sepsis, could be a million things. So really, do these stroke scales predict those patients if they're strokes and if they're LVOs? What is the benefit to LVO patients? And does the transport delay harm non-LVO patients and patients who aren't even strokes? Not to get into too much methodology or statistics, but what this is a slide. These studies came from the military, the ROC curves, and they used to be used for radar, but we also use these to look at sensitivity and specificity in studies. And the bottom line is, the straight line is the number of patients by chance that would be identified. So if I walked into a room with 100 stroke patients and I tapped on everybody's head and said, you're not an LVO, you're not an LVO, I'd be right 90% of the time, correct? Because 90% are not LVOs, that's pretty good. Well, not really, I didn't add anything, okay? So what these curves, the straight line is the number of patients who would be identified in the correct category by chance. The curved line is what is added to that by the test.
So I think the phrase from the American Heart Association is key. Hopefully future research can help determine the optimal methods for triaging patients appropriately from the field. But I think so far, we know that it's very hard to identify large vessel stroke patients, and it's even hard to differentiate non-stroke patients from LVO patients. So I don't think we have any data to validate transporting these patients by a primary stroke center. Right? Thanks. Any questions?
A lot of remarks. Thanks, everybody. And we made it for yet another year. And we'll see you all for the 6th annual conference next year on September 25th. Thank you.